In this module, I will be explaining about the thyroid, that is, about the non-neoplastic conditions of the thyroid gland. So, before going into the pathology of this non-neoplastic conditions of thyroid, we must know the basics of the thyroid gland. So, here you can see that as this is the thyroid gland, this is a thyroid gland. So it is butterfly shaped or H-shaped gland that is present in front of the trachea and the esophagus. So you are having two lobes, one is a left lobe and one is a right lobe, that are joined together by a portion that is called as isthmus. So looking at the normal histology of the thyroid gland, so these are the thyroid follicles, and these thyroid follicles, they are filled with colloid, and you can see that this thyroid follicles, they are lined by, here there is simple cuboidal epithelium or low columnar epithelium, and this colloid, it consists of thyroglobulin, and this thyroglobulin, it is Pas positive, that is periodic acid shift. It is a stain that is used. So now about the physiology of the thyroid gland. So it is regulated by a hypothalamo pituitary thyroid axis, that is, the hypothalamus will release thyrotropin releasing hormone that will act on the anterior pituitary gland, and it stimulates the release of the thyroid stimulating hormone. So this TSH, it go and binds to the TSH receptor which is present on the thyroid gland and activate a G protein. The GTP is converted into GDP, and there is increase in the level of cyclic AMP. This increase in the level of cyclic AMP, the thyroid hormone is released. So now, what are the clinical presentation of hypothyroidism and hyperthyroidism? So, the thyroid disorders will be presenting clinically as hypothyroidism or hyperthyroidism. So, in hypothyroidism, there will be goiter, that is enlarged thyroid. So, the thyroid gland will be enlarged. In hyperthyroidism also there will be this goiter, and in hypothyroidism there will be weight gain and there will be increased appetite. So even due to increased appetite is present in hyperthyroidism. In hypothyroidism there is weight gain, whereas in hyperthyroidism there is a loss of weight. In hypothyroidism, the level of T3 and T4 is decreased, whereas in hyperthyroidism the level of T3 and T4 is increased. So when the level of thyroid hormone is decreased, due to feedback regulation, more TSH is being produced to increase the secretion of thyroid hormones. So the level of TSH will be increased in hypothyroidism, whereas the level of TSH, it will be decreased in hyperthyroidism. So in hypothyroidism, then there will be depression, mood swing, then irregular menstrual period. So due to decreased activity there will be constipation, memory problems, and there will be cold intolerance. So there is hair loss in both hypothyroidism as well as hyperthyroidism. So in hyperthyroidism, the thyroid hormones are increased. So there will be heart palpitation, tremor, then heat intolerance. There will be disturbance in the sleep. There will be weight loss. So there will be increased appetite, and due to increase in activity, there will be diarrhea. Then there will be anxiety, nervousness, sweating. So these are all characteristics of hyperthyroidism. I'm just brushing through these basics. Now, coming on to the topic of proper. So, first I will be discussing about the hyperthyroidism. So, in this hyperthyroidism, the level of thyroid can increase either due to a primary cause or due to a secondary cause. The primary cause example are the Graves disease, toxic multinodular goiter, toxic adenoma. Whereas the secondary cause, it happens when there is increased level of TSH, that in case of a pituitary tumor. So if there is a pituitary tumor and that leads to increased TSH. So any pathology in the pituitary as well as hypothalamus comes secondary. Any pathology that comes within the thyroid gland comes as primary. So now what is this Graves disease? So the Graves disease, it is more commonly seen in the females than in males, and it is seen in more commonly in the age 20 to 40 years of age, and it is the most common cause of endogenous hyperthyroidism. So the pathogenesis. So what is the pathogenesis behind Graves disease? Actually, the Graves disease is antibody mediated. That means the antibody will be coming and binding to its receptor. So it is a type 2 hypersensitivity reaction. It is because it is antibody mediated. The antibodies that is present is the thyroid. Due to when the antibody binds to the receptor, it increases the secretion of thyroid hormone. So the antibody that we can see is anti-thyroid stimulating immunoglobulin. So this is an antibody that is stimulating the thyroid gland. So this disease is associated with certain genes. So they are associated with CTLA4, PTPN22, HLA-B8. So these are the genes, they are associated with this disorder. So in Graves disease, there is a clinical triad. So there will be, in this Graves disease, there will be hyperthyroidism, plus there will be infiltrative ophthalmopathy, and there will be infiltrative dermopathy. That is, there will be pretibial myxoedema. So this edema, it is of non-pitting type. So in Graves' disease, so when we are looking the thyroid gland grossly, so when we are looking at the thyroid gland grossly, you can see that there is symmetrical enlargement of the thyroid gland. That is, the thyroid gland will be, it will be red in color, or it will be meat like or beefy like thyroid gland. So when you are looking microscopically, that is on the H&E staining, there will be hyperplastic follicles. So this is a gross morphology, and this is the microscopy. So here you can see there is hyperplastic follicles, and then you can see the papilla. Actually, it is a pseudopapilla. There is no fibrovascular core, and then you can see there is scalloping of colloid. Scalloping of colloid. That means that the colloid is, you can see that the colloid is taking the shape of the epithelium. So the next one in hyperthyroidism is the multinodular goiter, and this is a clinical diagnosis. So grossly, in the gross morphology, you can see that there are multiple nodules of varying sizes, and when you are looking onto the microscopically or on H&E stain, you can see that there are follicles of variable sizes, and there are degenerative changes such as calcification and hemosiderin laden macrophages. So next, about the hypothyroidism. The most common cause of hypothyroidism is iodine deficiency, and the most common cause in areas where the iodine are sufficient. So in that cases, the Hashimoto Thyroiditis. So this is the most common cause of hypothyroidism in iodine sufficient areas. So what is this thyroiditis? Itis indicates that there is inflammation. So there is inflammation of the thyroid gland. The Hashimoto thyroiditis, it is an autoimmune destruction of the thyroid gland by the antibodies. So there are antibodies that are synthesized against thyroid peroxidase, that is anti-thyroid peroxidase. Then there are antibodies that is synthesized against thyroglobulin, anti-thyroglobulin, and there are anti-microsomal antibodies. So these are also associated with certain genes such as CTLA4, PTPN22, and HLA-B8. So when you are looking at the gross morphology, you can see that the thyroid gland is enlarged diffusely. There is diffuse enlargement of the thyroid gland, and when you are looking at the H&E staining, that is microscopically, you can see that there are lymphoid follicles. So you can see that there are lymphoid follicles with germinal centers, that is called as struma lymphomatosum, and there is Hertel cell change. Hertel cell change, otherwise called as oncocytic cell change. So the Hertel cells means the cells with abundant eosinophilic granular cytoplasm due to excess of mitochondria. So clinically he presents with hypothyroidism, and there is increased risk of developing the papillary carcinoma of thyroid, non-Hodgkin lymphoma, which is also known as extranodal marginal zone lymphoma. Then there is an increased risk to develop autoimmune disorders like rheumatoid arthritis and SLE, etc. In hypothyroidism, another non-neoplastic condition is a subacute lymphocyte cytic thyroiditis. Thyroiditis. So this is also known as painless thyroiditis, and it is a self-limiting condition. It usually occurs in the pregnancy. So when you are looking at the microscopy that is on H&E staining, you can see that lymphocytes, that is there is dense lymphocytic infiltrates, but there is no Hertel cell change. That means there is no, you cannot see the cells with abundant. So what are Hertel cells? The cells with abundant eosinophilic granular cytoplasm due to excess of mitochondria. So these cells you cannot witness in subacute lymphocytic thyroiditis. It was seen in the Hashimoto Thyroiditis. So another condition of non-neoplastic condition of hypothyroidism is D. Quervain's thyroiditis. So in D. Quervain thyroiditis, there is a painful enlargement of the thyroid gland. So when you are taking history, there will be a viral infection such as Coxsackie, mumps, measles, because after this viral infection, it affects secondarily, that is painful enlargement of the thyroid gland, and this is also a self-limiting condition and no biopsy is done here. Another non-neoplastic condition is Radial Thyroiditis. So in Radial Thyroiditis, the characteristic feature of thyroid gland is stony hard. You can feel that the thyroid gland is stony hard. So the pathology behind it is due to dense fibrosis of the thyroid gland. And you must think the main DD when you have a stony hard thyroid gland is thyroid malignancy. So that's all about the non-neoplastic condition of the thyroid gland.